Thank you, Dirk. These are my disclosures. So it's well known that when we have to work in the below the knee area, this is a little bit more challenging because we are dealing with small vessels, especially if we compare with the above the knee, the SFA and the POP region. In the majority of the cases, we have long lesions, and lesions are represented by occlusions more frequently than stenosis. And also very important that in majority of the cases, lesions are heavy calcified. So how we can do this, how we can manage, and we observe from the previous discussion that obviously we don't know right now the answer. There is not an agreement, but we have different options. One of that is for sure the use of the atherectomy. Honestly, it's pretty strange that a European guy is going to talk to the US colleagues about atherectomy, basically because the use of atherectomy, especially in Italy, is less common than in the US due to the difference in terms of reimbursement. But by the way, we know, better than me which are the advantages, that we can use this device not only as a standalone therapy, but also in preparation of the use of a simple dilatation with a plain balloon, but also for DCB or DES or bare metal stent. Obviously, this is very useful in case of in-stent restenosis. There are some controversial regarding, the vessel perforation and also, the learning curve and the cost. The atherectomy can be divided in 4 different groups. We have directional atherectomy, rotational, orbital, and also the laser. All of them give us the possibility to perform a second step of the procedure using a low inflation balloon. And this is very important, especially to reduce the stress on the arterial wall and so reduce the possibility of intimate hyperplasia and residual and recurrence of stenosis. And definitely this is one of the key points in vessel preparation, also not only for the drug-eluting balloon, but also for drug-eluting stents. Each of them presents some characteristics and some advantages and disadvantages. You can see here the majority of all the devices available. There is also, just to remember you that the Phoenix is the only one that we consider a hybrid device because combine the characteristic of the directional atherectomy plus the rotational atherectomy. Obviously, selection must be performed according to the characteristic of the lesion, because if you have something that is pretty soft, maybe it's much better to have a device able also to make a sort of aspiration. If you have a highly calcified lesion with a circumferential distribution, the orbital atherectomy maybe is the best choice. Directional can be selected when we have just, an eccentric lesion that help us to remove the plaque in that area, but to preserve the healthy portion of the vessel. But also, on the top of that, depends on how you are familiar with the device, because all of them have some, tips and tricks to avoid complication and to get the better outcome. If we go on the literature, there are several experiences regarding different types of devices. This is the confirmed registry. There is a huge study was conducted in more than in 200 centers in the US, more than 3,000 patients using the orbital atherectomy. A sub-analysis was conducted evaluating the outcome in those lesions above and below the knee in terms of dissection, perforation, flow, vessel closure, spasm, embolism, and thrombus. And this is very interesting because you can see that below the knee, there was a higher rate of perforation, higher rate of spasm, but also a very low rate of distal embolization. So this is something completely different because that every time we're working in the safe popliteal region, we consider mandatory to use a filter, but it's not the situation when we work in the BTK area. Another sub-analysis was to compare patients with claudication versus those patients with critical limb ischemia, and also to evaluate the efficacy in according to the amount of calcium. They made a difference between mild and minimal classification versus moderate and severe. You can see this is the evaluation for that for 1 to 3 for claudicants, and the section was more frequent in those patients where there is a mild and minimal amount of calcium, and this is considered less than 50%. On the opposite, perforation was most evident in those highly calcified lesions, and spasm again more frequent in a less calcified condition. Just to stress that these data were not evaluated by a core lab. This is the evaluation for data for the 4x6, the most complex. And again, you can see that the dissection, spasm, and embolism were more frequent in the less calcified lesions. So this is something that we have to keep in mind, and maybe you have to consider that maybe this device cannot be used in this setting. This is the study that was conducted, presented by Thomas Zeller regarding the use of the pathway. There is a different device with different technical characteristics. Again, above, below the knee, but there was also the evaluation of moderate to high calcified lesion in the 3 vessels below the knee, and this is the outcome. You can see that the clinical driven TLR is pretty good, especially after 1 year, exception for the tibioperoneal trunk, where there's a little bit more challenging area where maybe this device is not working very, very well. But you can see also that inflation of low inflation was performed in the majority of the cases after the use of the atherectomy. This is the study that was conducted using the Phoenix atherectomy device in 100 patients with more than 120 lesions. And you can see that the freedom from TLR was 88% after 6 months, with freedom from TBR around 86%. Very interesting also the technical success, 95%, and very low rate of major adverse events after 30 days, just 5%. Finally, the laser. This was investigated in 80 patients that for 4 to 6. There was a randomization between 47 patients with simple dilatation and then 48 patients where the eczema laser was combined together with angioplasty. And if we analyze the outcome after 3 years, so it is a pretty long-term follow-up, you can see an advantage for the clinical improvement, amputation-free survival, and freedom from target extremity revascularization in the patients that were enrolled in the group who were treated by laser plus angioplasty. So the combined treatment seems to be much better than a single and a simple dilatation using conventional balloon. This is just to show you a case of a complex patient who is diabetic, heavy smoker, with an ulcer on the right foot. You can see multiple disease in the anterior tib and the posterior tib with a pretty long amount of calcium and very poor distal runoff at the level of the foot. After the standard recanalization, you can see here also the amount of calcium. We use the Jet-stream atherectomy, and immediately after, this was pretty good outcome. You can see that the vessel is pretty nice, but we decided to complete the procedure with a simple dilatation. This is with the amphibian dip, 3 millimeter in diameter, and then we did the same thing in the anterior tib vessel. And this is the final angel. You can see how better is now the foot after the combined treatment of atherectomy plus DCB. And then we have also the 1-year follow-up of the anterior tibial that confirm the good outcome, in this case. So in conclusion, we can affirm that there is still, a valid position for the atherectomy in the BTK region. Obviously, this can be used as a standalone therapy, but also in combination with a simple angioplasty or drug balloon. This is still an open discussion. Obviously, the selection of the atherectomy must be conducted according to the characteristic of the lesion, but also, in my opinion, it's very important how familiar you are with the atherectomy. What you are looking for, obviously, for more data that can stress more which device is better in which condition, and for European side, also the cost is something that we have to keep in our mind. Thank you for your attention.